Hello out there in television land. Welcome to the summer edition of It's Your Health. Philip Benyo with Philip Benyo, bringing you the best and latest in healthcare information. We'll be right back after this brief commercial message. Remember, you're watching It's Your Health, your leader in healthcare. We'll be right back. Welcome to the first edition here and segment of It's Your Health. Philip Benyo with the Fipster, broadcasting to you live over the information highways that Samsung Production provides us. We're here to bring you the latest and the greatest in healthcare information. It's been a quick summer so far there, Fipster.
That's been nice. You're always ending summer before it starts, though. So
That's
try to
right.
enjoy it while it's here.
The glass is half empty.
All righty. Let's get to some headlines.
All right.
Okay. I think we touched on this before, but calcium scan can help predict premature death risk.
Right. Apparently you can have calcium buildup outside the artery, which is, we're talking coronary arteries at this point, and they don't really represent a blockage. Where we worry about calcium deposits, of course, is when they're on the inside of the artery. And they're using CAT scans these days to find out if you have any significant lesions. I don't know, I'm not so sure about this. What are your thoughts, Phil?
Well, it's a certainly very accurate test. Unfortunately, no insurances really are paying for this test. It's about a $200 test. And really, all this is going to help you decide is whether or not someone needs to be on a statin. And there's better ways to really measure that. Certainly, you could go for this, but if this is what you're really hung up about, you know, for $4 you can get a statin and try it out, and you're going to lower your cardiovascular risk.
Right. We're going to talk a great deal about statins later on in this show, so stay tuned. Next headline, Fipster.
Watchful waiting common in prostate cancer.
Well, you know, we're going back and forth on prostate disease, and it can be very confusing. In the olden days, we would do a digital rectal exam along with a PSA. We would still like to do a digital rectal exam every year. Using the PSA is somewhat controversial. I still like to use it. We've picked up early cancers using that. Some patients go on to biopsy, maybe didn't need a biopsy, and I think that was the concern initially. And I think what they're trying to tell us is that prostate cancer is a slow-growing disease, and some urologist will tell you you're going to die of something else besides your prostate. Is that pretty much it?
Yeah, I mean, chances are at 80, you know, you're not going to die from prostate cancer even if you get it. I think the key really is to start that screening early. It wasn't that long ago that the urologic associations changed the screening age from 50 now to 40. And so for those late 30s guys out there, it's coming a lot sooner than you thought, you know, that we have to start looking for prostate cancer, because these younger tumors in younger individuals are certainly more aggressive because you're making more testosterone at that age, which is the fuel for prostate cancer.
Yeah, that's a good point. So, especially if it runs in your family, you need to get prostate screening done at an early age.
Moving on, chronic ills may add up to shortened lifespan.
Yeah.
Yes, so.
Tell us something we don't know. I mean, you can only carry so much of a heavy cross, and you know, as the cross gets heavier, the illnesses are going to pile up. And the big thing there is also emotional health as well. I think how you deal with illness is just as important as the illness in and of itself. You'd say so?
I guess so, yeah. I think the key is you know, when someone who's already had a stroke and already had is already a diabetic and is already hypertensive, and they have all these dings against them, you know, unless we're really being aggressive with risk factors, it's not reasonable to think we're going to really advance ourselves, you know, quite far in age. And it's important to sit and get ahead of these chronic illnesses and you know, treat them and treat them appropriately and very aggressively.
Right. I had an old German professor teaching me medicine. He says, you know, we're like wagons, and when all the wheels get loose, look out. And I think that's what they're getting at.
Let's move on. We said we're going to talk about statins, and I think statins are worth it to talk about. They're very important to us, and they're some of the number 1 and 2 prescribed drugs in the world right now. So the American Diabetic Association recently announced that and this is, again, a no-brainer, we've talked about this for a long time, give statins to just about all diabetics.
Exactly. Diabetes is a vasculopathy. That is to say, it affects all the blood vessels going from your head to your toe. And statins help stabilize those blood vessels. They lower inflammation. They reduce plaque buildup. I really love statins, and I can't think of too many patients who we started on statins that ended up having trouble. I mean, do you really?
The side effects are transient. I don't think we've ever had anybody ever have any long-term sequela of a statin. Now, keyword inflammation. Let's take it a little bit further. Statin use is linked with lower risk of new onset irritable bowel disease.
Right. Well, you know, again, it's a anti-inflammatory, and it's cutting down on this vasculopathy. And those blood vessels are going, you know, all over the place. So, you know, we're talking, again, head to toe and all parts in between. So we have noticed that patients who have inflammatory bowel disease actually have, is it less disease or less flare-ups, or how would you describe that?
Well, I haven't really thought of it that way. You know, this is the first time I'm reading this headline. This is the first time I'm reading this, so I think it'll be very interesting. Kind of look in the future and say, you know what, part of your management, well, maybe we should talk about looking at your cholesterol. And lastly, statins linked to better outcomes with hepatitis C cirrhosis. Now that's interesting because with liver disease, we were told to stay away from statins, and now this is 180 degrees.
Right, it is. And again, I think it goes beyond cholesterol. I think the statins are one of nature's, if you will, fountains of youth. And I think you're going to do better on them than not. And I really would, and I know that there are people out there and they read that it may cause Alzheimer's and it causes muscle aches and pains, and the list goes on and on and on. But nevertheless, I really think that if you can take it, you should.
Yeah, if you're going to take a pill to a desert iron to live longer, you know, statins are it. You know, they're going to help you live longer, just about across the whole board.
No doubt.
With relatively low risk. And I was combing through some books and I found this cool little picture.
Ouch.
We don't quite see anything quite this severe from time to time, but this was an interesting case from Ireland, no less.
Yes, that is a sort of the beginning of a hammer toe, if you will, or I'm not sure the term for that in the pediatric literature.
This is a hallux varus, varus meaning
goes out.
Medial
right.
deviation.
And so there's no shoe that's going to fix this or insert. This is something that's going to probably require surgical care and treatment. And I think the big part is when you start seeing your toes do this, so-called bunions, hammer toes, things like that, get some early podiatry consultation in. Don't wait till something like this happens.
Yeah, this gentleman ended up having to get that opened up, re-broken and fused, and he ended up being able to wear his normal shoes, but it wasn't without a fair amount of work.
Well, so, you know, we always say this is the fastest half hour in television history, and so it goes. We're already through the first break here at It's Your Health. Stay tuned and you're going to learn some more information. Thank you for watching us in all the counties around our area. Remember, you're watching It's Your Health, your leader in healthcare information. We'll be right back. Welcome back to the fastest 30 minutes in television land out there, and Philip Benyo with the Fipster, talking to you about healthcare information that can affect your life. And speaking of that, make sure you check with your healthcare provider before doing any of the things that we talk about here on It's Your Health. Right, Fipster?
That's right. Really double check.
There you go. Moving right along.
Let's talk about, this is another pretty interesting headline, pretty simple. ACE inhibitors versus ARBs are showing similar cardiovascular outcomes.
Yeah, I went back, we're cleaning out our basement, by the way, and I found my old pharmacology books from med school. You know that there's not anything in there about an ACE inhibitor as for blood pressure or an angiotensin receptor blocker. They didn't exist, believe it or not. These particular drugs, ACE inhibitors and ARBs, are key and central to your health. They lower blood pressure. Keep in mind, hypertension is one of the most common diagnoses that we make. It's also one of the common diagnoses we don't make, and therefore don't treat. And silent hypertension is a silent killer. So, you really need to get your blood pressure checked. ACEs and ARBs are one of the cornerstones of treatment. Of course, if you're a diabetic, getting back to that, not only should you be on a statin, but you should be on an ACE or an ARB to promote kidney health. And they're relatively inexpensive, very efficacious drugs, medications, low incidence of side effects. You can get cough, maybe 1 out of 10 times with an ACE. We see that on people who are on lisinopril, for example. They say, I have this cold that won't go away. It could be that medication. But Phil, what's your take on these medicines?
I think you covered it all. There's
Really?
nothing much. I mean, I'll move forward.
Oh, man.
Medicare covers lung cancer screening.
Yes. There is no good, or at least there had been no good way of checking and screening for lung cancer, the number 1 or perhaps number 2 cancer in our area. And chest x-rays, of course, are of no value. CAT scan imaging, you're subjecting yourself to a fair amount of radiation. And again, when you do a test, it may find something that may subject you to a procedure that you didn't need. But nevertheless, if you fit a certain criteria, I think if you smoke more than 30 packs of cigarettes per year, is that? Or
It's 30 pack years. So a pack of cigarettes a day for a year is 1 pack year. So if you're a pack a day smoker and you've been smoking more than 30 years, if you're between the ages of 55 and 77, Medicare will actually pay for the CAT scan. Now, we order CAT scans actually a lot now, or more often, to screen for cancer because this has been out for a little while.
Right.
But for some people, their insurance will require a chest x-ray first, or sometimes we have to kind of cook up a way to get a CAT scan. And CAT scans probably is the best test to look for a goober or some type of tumor that may require further workup.
Yeah, I would encourage you to get a CAT scan. It's kind of going to fall under that same thing as mammography, colonoscopies. It may be an accepted way of screening for this.
Let's moving on. This was an interesting one. This one really caught me off guard. Cimetidine, or Tagamet, is used now for the treatment in sexually inappropriate behavior in patients who have dementia.
We see this in the nursing homes a fair amount of time. We have an old guy who inappropriately says things to other females, grabs them, is very disruptive for the staff. You end up having to call the cops, and it creates all kinds of nonsense. And it's pretty hard to extinguish. But nevertheless, this case report is useful in terms of promoting cimetidine or Tagamet, which is a stomach ulcer medication. And apparently it changes the hormones enough that in this case report, the behavior, the inappropriate sexual behavior was extinguished.
What about sexually inappropriate 40 and 50-year-olds?
I don't know, my wife will be starting me on Tagamet. I'm going to see a bottle of that at home probably, something like that.
All righty. Well, we're going to move to a little bit different topic. Something that we don't talk enough about, but certainly is more and more prevalent in our society, is the diagnosis and management of hepatitis C.
Right, exactly. It is unfortunately making a comeback, and I don't know if it has to do with the sexual soup that we're currently swimming in, or the drug abuse, or all of the above, but nevertheless, Hep C is making a comeback.
Yeah, there's certain things we look for. What we're actually now starting to do is screen a whole different population. Elderly are actually recommended now to get a screening because there's a chance they had a blood transfusion before 1992, or they received plasma before 87. Anybody who's been on hemodialysis, anybody who's engaged in any type of high-risk sexual behavior, tattoos at unlicensed places, especially older tattoos as well. And just IV drug use. That's really the one we're seeing, unfortunately, more and more of. And if someone already has HIV, there's half a chance they'll actually have concomitant hepatitis C as well. And so we're doing a better job of screening, I think, which is important.
And if you're out there, you may not actually have symptoms that would suggest it, at least to yourself. But some of the common symptoms: fatigue, feeling like there's something wrong, tired, weakness.
I think in the acute phase, it can be very almost flu-like, usually within the first 6 months of exposure. But after that, these people feel fine, and someone who's had it for 20 years and it's a mild case, They feel fine. It's often a diagnosis we find by accident.
Right.
You know, it's never that, well, I bet this person has Hep C, and you do it and it's positive. It's, well, better make sure they don't have Hep C, and you do it and it's positive. Well, what do we do from there? You know, it's very simple blood work. You know, that blood work takes 3 days to come back. The treatment can vary. You know, unfortunately in our area, nobody does treat hepatitis C, or hepatitis B for that matter. You're best served finding a hepatitis clinic. And there are clinics in our somewhat immediate area that do treat hepatitis and treat it very well. But there is a lot of testing that needs to be done to see what type of treatment category you fall into and whether or not you need treatment.
Right, but there is good treatment available, and
Absolutely.
I think that's the important thing, is make the diagnosis and then get referred for care and treatment.
Yeah, we don't see people really dying from hepatitis C. It's just
Right.
something, an oh by the way diagnosis they have.
Right.
And they can carry that into their 70s, 80s, and so on. Lastly, we see a lot of this. We get an ultrasound report back because we see an elevated liver function test and it says they have fatty liver. And you know, in the past, we really couldn't tell people, well, put your liver on a diet. You can't really do that. But you know, there's some now tools we have to help at least combat fatty liver disease.
Fatty liver is a very common diagnosis. You may find no symptoms whatsoever, and it could be found by dumb luck. You may have an elevated liver function test. Ultrasound imaging will say that. Alcohol, of course, is probably one of the more common reasons for fatty liver. But if you have fatty liver and you don't know what to do, believe it or not, case reports have suggested vitamin E, of all things. Vitamin E will help that particular condition, along with perhaps some diet and weight loss. But nevertheless, think about that, vitamin E.
Yeah, and there's some instances too where people have some rather significant fatty replacement of their liver, where their liver becomes more fat than liver. Those have to be referred out actually to the same people that run the hepatitis clinics.
Right.
To have that just further looked at.
Well, I warned you this is the fastest 30 minutes in television land. We're going to be right back with our third and final segment of It's Your Health. Remember, you're watching your healthcare leader in information. It's Your Health. Welcome back to the third and final segment. I can't believe it, Phil. It's just like we
We
started.
need to start having a fourth segment.
Is that right?
That'll be like really weird stuff.
That's
Talk
like a-
about fringy things.
That sounds like something on Sci-Fi Channel, the fourth segment.
Fourth segment.
Okay.
We broadcast it only late at night, which our show usually is on, right?
That's right. The 2 in the morning.
Alrighty, let's move on to some headlines again. We'll try to rip through these and get moving. All right, controlled release oxycodone or OxyContin is not as effective for neuropathic and fibromyalgia type pain.
Yeah, we're seeing more and more of, and we're making more diagnoses of people with chronic fatigue, chronic pain, chronic pain syndromes, fibromyalgia. You know, those diagnoses are out there, but they're very difficult to treat. And one of the things we want to stress is trying to steer away from the narcotic use. And these particular illnesses, assuming you have them, respond very well to other forms of treatment like tricyclic antidepressants, some of the neuropathic pain models like Lyrica or Neurontin, something along those lines. Exercise, physical therapy, beautiful response. But you know, people don't want to do that because they're in pain, they don't want to move, and they would rather get their pain relief by taking a narcotic, which has in and of itself short-term gains, but more long-term problems.
Yeah, that's exactly it. And you know, the thing is with a lot of these chronic syndromes, you know, we give them the word chronic for a reason. If they're acute and we could cure them, we would, but we can't. And so sometimes it's not a very reasonable expectation to manage this patient to be completely pain-free. I mean, we certainly could narc them up to the point where they would, but they'll be drooling on the couch. That's not a quality of life. And so it's hard. These are hard conditions to treat, and it usually requires a multifactorial approach, you know, both from a rehab standpoint and a medical standpoint.
Yeah, and don't forget there's a tremendous emotional component to this, and a lot of these patients are rightfully anxious and depressed, and if that's not addressed or treated, you can get symptom magnification. The patient's symptoms are magnified by the fact that they have a depressive disorder.
I'm going to take the last part of these headlines to talk about two new drugs. And I think a perfect time to talk about Belsomra, which is a new sleep hypnotic or sleep agent, would be now, because that's one of the important treatment protocols, I think, for treating fibromyalgia, is to make sure we're getting proper sleep.
There's no doubt all these people do not sleep well for whatever reason. And they did studies on young Army recruits, and they woke them up every couple of minutes to try to simulate battle activity. And a lot of them got fibromyalgia just by not going through their regular sleep cycle. So sleep hygiene is very important. The sleep hypnotics are problematic. They have tolerance, which means you get used to them and they don't work. They have drug side effects. They increase the fall risk. But there's a new generation now of sleep aids, which I think is going to be just revolutionary. It's a new pathway that maybe you can enlighten us on.
Well, I think that Belsomra certainly fits that category. It's a completely new class. The best way I describe it to patients is I tell them first, I said, now you have to sit down because this is going to blow your mind. I'm not going to help you fall asleep. I'm just not going to allow you to stay awake. What does that even mean?
Yeah.
But that's what this medication does. It helps prevent wakefulness. And a lot of people who have sleep disorders, it's not that they can't fall asleep, it's just they can't prevent staying awake. They just are tuned, and hormonally their circadian rhythm is pumping them to stay awake. And this actually shuts down that mechanism.
Yeah.
So you naturally will just go down. And for the people who've been on a bunch of different of the hypnotics we have out there, the Restorils, the Ambiens, Lunestas, and they just kind of work, they don't work. You know, it's more like taking a sledgehammer to a walnut. You try Belsomra at a low dose and it's just magic. And they don't feel tired in the morning, they're not narked out. It really has worked well.
Yeah, I've been very impressed by it. I gave some samples out and patients just love it. No side effects, and it works. It stops wakefulness.
That's it.
That'll put you to
Allow you
sleep.
to stay awake. All right, lastly, we'll talk about this real quickly. Stiolto. This is a new inhaler. It's a long-acting beta agonist combined with the anticholinergic Spiriva. It's a once a day, and that's great because most of the inhalers we have with long-acting beta agonists are twice a day, pumps, where this is just a nice once a day.
And some of the inhalers that came out, as you may know out there, have this very micronized powder, which ends up, if you don't use it right, even if you do use it right, some of it ends up in the back of your throat. You end up coughing, you get yeast infections. Get a load of this. This is a no-brainer. You don't have to do anything except put your mouth on this and push the button, and voila, that mist goes into your mouth and down your tracheal bronchial tree once a day. Just unbelievable, and the technology is just great. So
neat stuff.
It is neat
just
stuff.
A cool delivery mechanism. They have this mechanism for a couple other inhalers, but I think this is one of the more interesting ones out there.
Yes.
Moving on, let's talk about. I know this is something that we see. We see advertisements in the paper, church bulletins that we're going to have in the basement of a church. We're going to be doing carotid Dopplers, life screening. These are an interesting problem.
Well, people come in and they bring these brochures and say, I want to go for this screening, which is not a bad idea. They want to check your sugar, your cholesterol, see if your carotid arteries have any plaque, see if you have an abdominal aortic aneurysm. All these things are great. The problem is they are just screening tests. To be quite honest with you, it's a money-making event. These things are for profit. They're not doing them for free. And they will make your wallet lighter, if anything else. And then you're left with the problem that the screening tests may be inaccurate. And I guess if you really want to get a bang for the buck, I would see your physician and tell them what you want screened. We can do carotid Dopplers. We can do ultrasounds of the abdomen. These are legitimate, reproducible, verifiable. We can believe in the studies, if you will. And chances are they would be paid for. Chances are, if you have underlying illnesses such as hypertension and hyperlipidemia, and if you have an illness, we can pretty much justify a screening test, if you will. And so I'm not completely, I'm all for screening tests, but I'm not so sure this is the right way to do it.
Yeah, I think an ultrasound tech that you don't know and a radiologist you never heard of working in some basement with equipment that's getting banged around all over the country just doesn't seem reliable to me. Whereas when I'm sending someone up to the Health and Wellness Center, I know that ultrasound tech, I know how good they are, I know the radiologists that are reading these are top notch. And so I put a lot of faith and trust in that. If someone comes in a particular problem, that it may lead me to think they may have an abdominal aortic aneurysm, which we'll talk about hopefully briefly. and they say, well, geez, 6 months ago I had a screening tastement in this church basement. Am I going to trust that? No, I can't trust that. I still got to take a look.
Yeah, I think stick with the bake sales and selling pierogies and leave the screening to the professionals, if you will. And speaking of aneurysms, Phil, briefly, maybe you could give us the thumbnail cliff notes of an abdominal aortic aneurysm.
Well, abdominal aortic aneurysm is think of it a bubble on the tire. It's this abnormal protrusion or blowout on the sidewall of the aorta, which is the main artery coming off the heart. They can get bigger. They usually are pretty asymptomatic. On exam, sometimes we'll feel a pulsatile mass, and that's actually the aorta pumping. As they get bigger, or if they become more problematic, they can sometimes present as having low back pain. Rarely they can rupture, which 50% of people who have a ruptured abdominal aortic aneurysm never make it to the ER. But they can be found early and monitored, and we generally will watch them with ultrasounds every year. If they get a little bit bigger, every 6 months. And it's important to have these things monitored at some point. Usually when they get over 5 centimeters, that's when surgeons are going to talk about cutting these out. They can open you up and remove the whole aneurysm. Now they can go through your groin through a catheter and actually put in a stent, if you will, or do an endo repair, which is pretty cool. Treatment, avoid smoking, moderate alcohol use, make sure your blood pressure is nice and low, and I think the biggest thing is make sure you're on a beta blocker.
Yep.
That helps cut down on what we call shearing forces.
What can I tell you? It says it all. Thank you for joining us for another edition of It's Your Health, bringing you information into your home, hopefully entertaining you along the way as well. Remember, It's Your Health. We're your leader in healthcare information. Thank you again.